Welcome to the September National Action Alliance for Patient and Workforce Safety National Webinar. We'll be starting shortly. Stay connected with us. Subscribe to the National Action Alliance monthly bulletin and email us at nationalactionalliance@hhs.gov. My name is Jen Schreiber. I'm a principal program analyst at Ripple Effect, and I also had the pleasure of serving on the Best Practices Learning Visit team with my colleagues Andrea Amadeo, Jason Scott, and Jackie Kim. This webinar is being recorded, and presentation materials will be posted on the National Action Alliance website in the coming weeks. Please use the chat function to ask questions and engage with us throughout the webinar. You can go to the next slide. Closed captioning is available. To use live captions, go to your meeting controls at the top of the screen and select More Actions, Language and Speech, and Show Live Captions. We'd like to extend a warm welcome to new and existing National Action Alliance members. We encourage all interested healthcare systems to visit the National Action Alliance website to understand the commitment process, which involves having an executive safety leader pledge on behalf of your organization. Organizations can formalize their commitment by submitting it via email to nationalactionalliance@hhs.gov. We have a packed agenda for today. We're going to keep things moving quickly so that we have time to take your questions later. First, I'm going to provide some background about how we identified the high-performing health systems. I'll also explain what a change package is and provide a sneak peek at some elements of the best practices change package, which is now available on the National Action Alliance website. Then representatives from our high-performing health systems will describe some of their best practices that are detailed in the change package. Finally, we'll wrap up with your questions and a roundtable discussion with our presenters. As you listen and participate today, please keep these questions in mind. Which characteristics of the high-performing health systems resonate most with you? And which actionable practices could you see your organization implementing? So how did we approach identifying high-performing health systems? We started with the assumption that healthcare systems with high performance on safety measures and strong HCAHPS responses across multiple hospitals would be systems that have safety culture, leadership, and governance practices that contribute to those results. We used publicly reported data to identify our high performers, engaged in rigorous pre-visit planning with each organization, and performed site visits using an appreciative inquiry approach. After the site visits, the team reviewed the information we gathered and drafted the theory of change that described our understanding of the systems and how they were achieving their performance. Then we assembled a 2-day technical expert panel to refine the theory of change and agree upon common language for the change package. This change package is designed so that every healthcare organization can find something they can take away and implement immediately. We wanted to show you how we identified the 3 systems you'll be meeting today to give you a sense of just how much their performance stands out. We started with a pool of almost 5,000 hospitals that submit safety data to CMS. Of those, 280 hospitals have reported at least 18 of the 24 safety measures we reviewed, and they perform better than the national average on more than 75% of those measures. Then we added HCAHPS patient experience measures. 88 of the 280 hospitals achieved an average HCAHPS rating of 3.7 or higher. Finally, we added 2 filters related to rural location and social vulnerability. This process left us with a list of 65 high-performing hospitals. It was encouraging for us to see that the 65 top-performing hospitals span 9 out of 10 CMS regions and 29 states. They also range widely in size from 25 to more than 1,000 beds and include a significant share of rural facilities. Next, we moved to looking at healthcare systems. Again, we started with the pool of almost 5,000 hospitals and identified 135 hospitals that are part of a system containing at least 6 hospitals. Only 5 of these healthcare systems had safety measures with composite performance at 75% above the national average or better. 3 of the 5 healthcare systems had more than one hospital on the list of 65 high-performing hospitals from the last slide. Here's that same data in a histogram format, so you can see the distribution of performance among the 135 health systems with at least 6 hospitals. Our hospitals in green at the end are our 5 that had the performance at 75% or greater, and our 3 healthcare systems had more than one hospital at the top of the 65 list. The 3 healthcare systems that had safety measures with composite performance higher than 75% above the national average and strong HCAHPS performance and had more than one hospital on the top 65 list are Houston Methodist, St. Luke's, and Mayo Clinic. Here you can see that our high performers were nicely distributed geographically and represent different regions of the country. Now that you understand how we arrived at our high-performing systems, let's discuss what we wanted to accomplish during our site visits. We sought to uncover and understand what each system's strengths and best practices are related to safety culture, leadership, and governance, and how these practices work together to develop a change package that can be used by any organization. A change package is a menu of strategies, change concepts, and actionable practices built from what we know works well. A theory of change shows us how the elements of the change package all work together toward the aim. Primary drivers are the main areas that might drive the change. Strategies are overarching approaches, so the big picture supporting each driver. Change concepts are more specific ideas that support strategies, and actionable practices are specific steps that you can take to improve. These nested concepts help us see that excellence isn't a result of the specific actionable practices alone. There is intention and alignment behind the steps. Here's our final theory of change for high performance and safety. As much as I would love to describe every element to you, we don't have time today. I am going to encourage each of you to go to the AHRQ website and download the change package, and there will be a link in the meeting chat. Instead, I want you to consider the 3 primary drivers and see the way that the strategies, change concepts, and actionable practices flow from them. Our orange driver is safety culture. It is the core value of each of these health systems, and it's created and sustained through purposeful actions. You will see a lot of language in the change package around purpose and intent. That was probably our biggest takeaway from the site visits. Excellence is not an afterthought for these systems. They aren't doing the actions detailed in the change package to fulfill a requirement or to check a box. They are living each of the primary drivers in practice for every patient and team member every day. The intent behind their actions is obvious, and the result is almost tangible. The green driver is about leadership. In these systems, leaders embody, cultivate, and reinforce the safety culture. They are both talking the talk and walking the walk. They care for their team's well-being and professional development. Because of this, when they set expectations of excellence, their teams rise to the occasion. The blue driver is about governance. These systems have governance structures that support safety and highly engaged governing bodies that drive strategic planning efforts towards excellence and safety. You'll notice only one strategy here, and that is govern with intent. Each of the high-performing systems has intentionally nurtured a shared vision for safety and committed to investing in the infrastructure needed to support it. Let's look at the safety culture change concepts. High performers view safety as a key part of the patient experience. Patients and their loved ones are an essential part of the care team, and their feedback is incorporated into the design of safety interventions. High performers prioritize the psychological safety of the workforce. They make sure their staff feels safe to voice safety concerns. They focus on processes and balance system and personal accountability when a safety event occurs. They recognize that psychological safety allows them to create and sustain a speak up culture. When the workforce feels safe, they're empowered to deliver safe patient care. High performers expect the workforce to report safety events and concerns, and they use structured methods to analyze events to drive improvement. An example actionable practice related to these concepts is using a systemic event review framework like the Just Culture algorithm that focuses on processes over people and balances personal and system accountability. High performers use objective data to make safety decisions. They monitor data in close to real time and present it in ways that can be understood and operationalized by the people closest to the work. High performers offer multiple opportunities for competency-based training that's grounded in their shared values. These competencies are introduced early during orientation, and they're consistently reinforced and demonstrated. Finally, high performers create channels for open and transparent communication across all levels of the healthcare system to ensure that patient and workforce voices are heard and addressed. They use multiple modalities for real-time, formal and informal communication, and consistently close the loop with timely feedback. A great example of this is the tiered huddle process. Tiered huddles are structured daily meetings that occur across multiple levels of the healthcare system. This creates a rapid channel for communication from the unit level up to senior system leaders. Let's pivot to leadership. High performers expect leaders to model safety behaviors and ensure leaders are approachable and accountable for maintaining the culture of safety. This is walking the walk. It's something we observed consistently during site visits at the 3 high-performing systems. They prioritize recruiting a workforce based on cultural fit. Their job descriptions emphasize safety, and the workforce is held accountable for providing safe, high-quality care. High performers actively support leaders to model the culture of safety through rounding and through regular engagement with patients and staff. These organizations nurture and value relationships as a means to build trust. They intentionally assess leaders for cultural fit and develop them through mentorship activities and succession planning. Again, high performers recognize that staff well-being and psychological safety are fundamental to safe patient care. They also consider workforce well-being and safety as key drivers to reduce burnout and turnover, and in turn, reduce burnout and turnover support safety. High performers empower the workforce to identify opportunities and solutions for improvement. They give their teams the autonomy and the resources they need to resolve safety concerns. They have well-developed programs tied to their values that recognize workforce achievements in intentional, visible, and enduring ways. Leaders actively decrease barriers for the workforce to do their jobs. Finally, we'll talk about governance. High performers recognize safety as a core value that's critical to their patient-focused mission. The vision is clearly communicated and embodied across all levels of the system. It guides short-term decisions and long-term strategic planning. And all of this together leads to a strong and highly visible culture of safety. High performers maintain a governance structure underpinning their safety program that supports decision-making based on the core values, collaboration, and accountability across the system. This governance structure facilitates the patient and workforce experience from the unit level, across disciplines and specialties, up to the governing body. It also provides a mechanism to disseminate and standardize safety practices across the system, while also allowing for adaptation as needed to respond to varying local conditions and cultures. Clinical and administrative leaders are held accountable for collaborating on safety decision-making. High performers dedicate substantial human and financial resources to support safety. They proactively invest in workforce training and development, technology, and other safety infrastructure. Each of our high-performing systems recognizes that safety, quality, and the patient experience are competitive business advantages, and they value harm avoidance as an independent ROI that's worthy of prioritization. Now, after that whirlwind of information, I am thrilled to welcome 3 members of the AHRQ Technical Expert Panel on Safety Culture, Leadership, and Governance. They've graciously agreed to represent their high-performing organizations. Due to the contributions of our speakers and their teams, the Mayo Clinic, St. Luke's Health Network, and Houston Methodist have each earned too many state and national awards for safety and quality to describe here. Dr. Sean Tittle is the Senior Vice President and System Chief Quality Officer at Houston Methodist. He oversees safety, quality, patient outcomes, and the patient experience across the system. His leadership spans areas such as data analytics, clinical informatics, infection control, and accreditation. A CT surgeon by training, Dr. Tittle earned his MD from Wayne State University and completed residencies at St. Mary's Hospital and Yale New Haven Hospital. He also holds an MBA from Rice University. He joined Houston Methodist in 2016 and previously served as Chief Medical Officer and Chief Quality Officer at Houston Methodist Baytown Hospital. Donna Sable has served as the Senior Vice President and Chief Quality Officer for St. Luke's University Health Network for more than 15 years. In addition to overseeing quality, Ms. Sable is also administratively responsible for other network functions, including care management, clinical documentation improvement, coding, clinical risk management, infection prevention, and clinical analytics. She has an MSN from DeSales University and holds a professional certification in healthcare quality. Pauline Byam has over 28 years of experience at Mayo Clinic, specializing in quality and systems improvement. As a leader within quality, she has been instrumental in operationalizing culture of safety tactical improvements, including tiered huddles and digital visual management boards. She's an active member of several professional organizations, including NAHQ and HIMSS. She holds an MBA from Viterbo University and certifications in healthcare quality, Lean, and Six Sigma. Let's extend a warm welcome to Dr. Tittle, Donna, and Pauline.
Happy Monday, everyone. I was very excited to find out that I was speaking and I was not on mute. It's an honor and a pleasure to be here, and I'm very grateful for the kind introduction. I would also like to encourage everyone who is on this call emphatically, download the change package. It's an incredible document, and the amount of work that went into it was really sort of mind-blowing to us as we watched our colleagues from Ripple Effect and AHRQ measure and manage every word in an appropriate way to make sure that it had the most meaningful impact to health systems. Next slide. I'm going to tell everyone a short story about an emergency room. This emergency room is on the east side of Houston. It is in a hospital that was about 300 beds, and that hospital was right near the industrial area of Houston, surrounded by refineries. The hospital had been in existence for about 75 years, and this part may resonate. We had seen more and more patients come in over the course of time, to the extent that the emergency room was very busy. It was always packed. There were always people in the waiting room. There could be dozens of people in the waiting room. There was boarders in the hallway. And the idea was, we're going to take about this 25-bed emergency room and we're going to expand it, and we're going to make it a 48-bed emergency room, and this was going to fix problems. And I think everybody who works in healthcare knows the ending of the story, which is now you have more rooms locked up and more people in the waiting room and more boarders. And so it was really an important operational and quality and experience measure for us to address this problem. About 90% of our inpatients came in through this emergency room. And so what we did is we mapped every patient's experience, including waiting times, and looked at it, addressed it, pulled in frontline and leadership from the emergency department and said, we need to completely redesign this process. And the conversations we had were about empowering the frontline to really deliver what they thought was the best quality of care. The issue had been, of course, that everyone was frustrated. They had learned hopelessness. They had learned helplessness. They wanted so much to deliver the highest quality care. That was the reason that they all went into healthcare, but were limited so much by the current process. And so one of the things that we did was give everyone permission to wipe the slate clean and say, let's completely redesign this. So instead of the standard process of bringing a patient back when a room was open and putting the patient in the room and then having an entire assembly line of people come in, go out, come in, go out, come in, and go out, what we did was we redesigned the process around the patient. So when the patient came into the room, the providers were there. They were all immediately assessed, and then all of the orders and the tests were delivered at the same time, and they moved out of the first phase of the emergency room to the second phase of the emergency room. In the second phase, that was testing and disposition. And what we did was we ran a pilot program, and we decided to run this new process one time. We ran it from 7 a.m. to 1 p.m. And at 1 p.m., for the first time in recorded history that we walked outside and we noted that the waiting room was empty. We went back and assessed all the data and found that we could predict how many patients were coming in per hour. We staffed appropriately, and 2 weeks later, we started the program again. We gave permission for everyone to stop it if they felt that there was any safety or quality concerns. However, that program is still in effect today. When we measured this, our net promoter score on the patient side went from the mid-30s to the mid-80s. When we looked at our disposition times, we realized that we had saved about 100 minutes out of every patient's experience in our emergency department. And I really want to bring it back to a couple of key points here. One is accountability, collaboration, and transparency. We were accountability to ourselves and to each other, and we collaborated around the patient, and we were very transparent with any problems that we had. The other was do not be afraid to fail. Fail early, fail often, fail forward. If anything hadn't worked, we would have retooled the entire process and made sure that we delivered the best care we could to our patients. Next slide. When we combine this with our hospitalist service and we embedded our admissions team inside the emergency room and started warm handoffs in the patient's room, the patients felt safer. They knew that the people who were taking care of them on an inpatient basis had had a full report, a download of everything that was important and meaningful to them. And when we combine that with in-person rounds, their families were able to ask questions. It was a fundamental game changer in the patient experience through our hospital, and it was all about conversations, and it was all about the freedom to change our processes. I want to thank Ripple Effect and AHRQ again for this opportunity to give this short story about our emergency room, and I'm going to hand it off to my colleague, Donna Sable.
Thank you very much. We go to the next slide. Hello, everyone. And again, I also want to extend my gratitude to our folks from AHRQ, Ripple Effect. This has been a phenomenal experience. Next slide. So it is all about leadership and identifying potential leaders and investing in those leaders to help move things forward in the organization. I always say when your work is meaningful and you love what you do, it greatly reduces burnout, and the culture in the organization becomes one that is very vital and uplifting. I hear from organizations all the time that either they don't have the resources that we are fortunate to have, or they have private physicians who it's hard to get them on board. I listed our anesthesia department. It is a private group, and they are actually and have led tremendous improvements across our organization. So I think the takeaway for anyone who's looking to invest in leadership is you can do this whether you have lots of resources and whether you have private physicians or not. So in our anesthesia department and across our network, we looked at developing our vice chair model, identifying these leaders and really investing in them. And we partner our chairs and vice chairs with a dyad partner administratively. So they are investing in each other. And we really develop the skill sets that we need to be successful leaders, how to coach, how to mentor, emotional intelligence. You can do some of this by book clubs with a lead person in your organization, how to have crucial conversations. So getting to a win-win and being respectful. Doing some inventories of our leaders, such as a 360 evaluation. And we've done Myers-Briggs inventories across all of our leaders, so we know our personality traits and how to work with each other. If you don't have organizational development support in your HR, we all have HR departments, and they can be critical in helping us to lead forward. My colleague, Dr. Tittle, talked about failing. You fail and you learn. Our CEO says all the time in healthcare, you have to take risks to grow. You're going to have failures, but you learn from them and you move on. So our leadership, again, private physicians in our anesthesia department have led an acute kidney injury project to improve outcomes, not only in our organization, but nationally on webinars, and developing using AI technologies, continuous monitoring of patients, which has greatly reduced our cardiac arrest rates by 37% over 2 years. So giving an upcoming leader a project that's meaningful and significant, supporting them and seeing how they can do with that will help you determine whether that leader can continue on and advance. Psychological safety, again, so important. Leaders have to model. So our physician chairs, our administrative leaders address disruptive behaviors as close to real time as possible. One bad egg can spoil the whole carton. So it's really important to address and keep people walking the talk. And then having your finger on the pulse. So do you know if you're doing a good job? How do you objectify everything? So culture of safety survey results. Our anesthesia department a year ago was not happy with the performance for their department of over 300 employees. So they set a plan in action, and this year their culture of safety survey has 9 of 11 of the areas in the top quartile benchmark. Also making sure that your staff is engaged, doing your staff engagement surveys, and we have been able to achieve very high performance in external studies on employee engagement. And then I think the other thing that leaders have to do to set the tone in the organization and that you can help in your organization is enjoy the ride. Celebrate those wins. You know, it's very motivating. We have an internal quality awards program that we set in motion about 18 years ago, and it's a very healthy competition. This year we have 79 projects that were submitted across our enterprise. So I think, again, create excitement, create meaningful work, develop your leaders, and you will see your performance not only improve, but sustain itself. So I'm going to turn this over now to our third colleague who's been working with us, from the Mayo Clinic. And I know she's going to do a fabulous job on governance. So I'm turning it over. I'm sorry, I just lost my note on this, but Pauline from the Mayo Clinic. Pauline.
Thanks, Donna. And thanks, as always, to the National Action Alliance and Ripple Effect and my colleagues from Houston Methodist and St. Luke's for invaluable work in pulling us together. We noticed when we were all together over a couple of days in DC how much we enjoyed learning from each other and continuing to take those learnings home back to our organizations. I'm starting out a little bit on the governance change package with our Mayo Clinic mission and primary value. The slide introduces our core mission and care model. We're driven to inspire hope and improve health, through integrated clinical practice, education, and research, as represented by the 3 slides in our logo. At the heart of everything we do is the needs of the patient come first. I'm going to come back to this again on the next slide because it's so important to who we are at Mayo Clinic. Our distinctive care model, team-based approach, triad leadership model further strengthens how we bring together diverse expertise, ensuring patients receive the best possible treatment. Next slide. Bringing this core mission into practice starts and ends with the patient. Our unique care model, our reach, and our teams are all grounded in a simple yet powerful value: the needs of the patient come first. This is not just a statement, it's a lived reality across Mayo Clinic campuses. Staff, when asked about our primary value, can answer without hesitation. You'll often hear when crucial decisions need to be made, do we go right or left? Do we invest in option A or B? You'll hear what is in the best needs of the patient resonate over and over again to guide those decisions from the front line to the top of the organization. One common thing I noticed in our gathering together to form this change package is that we all had an acronym outlining our key values and focused on a lot of the things that were relevant to that. Mayo Clinic's key values are centered around rich ties in a kind of helix DNA type model because it's so ingrained in our organization, and encapsulating around respect, compassion, integrity, healing, teamwork, excellence, innovation, and stewardship. These are depicted on the walls. They're ingrained in committee meetings and key decision makings and kind of guide our everyday work at Mayo Clinic. And this quote kind of encapsulates that the best interest of the patient is the only interest to be considered in order that the sick may have the benefit of advancing knowledge. Union of forces is necessary. So this is where the quote, where that needs of the patient come first. But I also want to point out how important teamwork is and the union of forces in this quote. And you'll notice it's from 1910, and many of those things still ring true today. Go ahead to the next slide. Building on this strong value-based culture, strategic planning is designed to keep these principles front and center. Short and long-term strategic plans are crafted to explicitly integrate shared values, mission, and vision, and are regularly assessed and refined. For instance, we set long-term strategies typically in 10-year cycles with annual reviews that adapt and refine those strategies. A core commitment within these plans is ongoing investments in safety, quality, and experience, recognizing that they're not just competitive advantage, but also essential returns on our investment. Our 2030 quality trinity of strategic imperatives defines our vision for quality by the year 2030. We set these now 5 years ago. 3 pillars being a category of 1. How do we differentiate ourselves from our peers, delivering reliable excellence and always safe, along with an unparalleled experience? They work together to form the bedrock of Mayo Clinic's dedication to outstanding healthcare and innovation. Next slide. How do you put that strategy into action? Intentional governance is key. How does your intention manifest itself daily? Asking yourself that question from the top of the organization to the frontline caregivers and support staff. Mayo Clinic recently invested in real-time patient care data reporting and analysis systems, enabling staff to access critical information quickly and making informed decisions. This picture shows a team gathering around a digital board displaying real-time data, fostering transparency, accountability, and rapid cycle problem solving. Adopting these practices, of course, raised concerns about the time commitment, as was the case when we implemented daily tiered safety huddles. Some worried about the added time. However, leadership made participation a core expectation. These huddles are not an extra task. They're integrated into our work. Leaders model active engagement, routinely asking, what can I do to help, when staff and leaders bring things up through the daily safety updates. The process has streamlined communication, reducing the need for additional meetings and emails. In fact, when the Ripple team visited, a unit leader reflected, yes, it takes time, but we're talking anyway. And now these huddles streamline the amount of separate conversations, emails, newsletters needed to occur each day to ensure the team knows what the team knows. Thank you again for the opportunity to share our journeys. I hope we demonstrated some similarities and differences amongst our organizations, while we all have an unwavering commitment to staff and patient safety. I'll now turn it back over to Jen Schreiber from the Ripple Effect.
Thank you so much for sharing with us, Dr. Tittle, Donna, Pauline. It was amazing to hear from you again. So now let's transition to our roundtable. I will direct the first question to each of you. And while I'm asking everyone attending, if you have questions for the team, please put them in the chat. So our first question is, considering each of your organizational experiences, how would you recommend that an organization interested in improving their safety performance best leverage the change package? Where should they start?
I'll take a stab at that first. There are metrics, and then there are processes. We always played to the processes, not to the metrics. And so it was about delivering the best care possible to the patient. What I believe that you find in the change package is a blueprint to do this for the organization. A philosophic blueprint and sort of an operational blueprint, from governance to how you treat your leaders, how you develop your team, and how you communicate.
I can jump in as well and kind of expand on Dr. Tittle's comments. And I think that I was happy to mostly to talk about governance, because I feel a little like if you don't have that values-driven culture at the base, it's really hard to make decisions that drive patient and staff safety. And we all had an acronym for our values. They were different, but we all had one. And I think that, and we reinforced those, and staff, I think, could articulate what that acronym was and what those values were. And that's key to making decisions going forward. And so I feel like that structural component needs to be in place first to start. But I do think there are daily things that we all operate in our own sphere of influence. So whether you're frontline manager all the way up to the senior leadership, if those values and those things are important to you, ask yourself, how are you manifesting those? How are you acting them out and living them every day? Would others around you say that you're demonstrating those values and that commitment to safety?
And I would just add, as we know, the secret sauce is your culture, and your culture has to be one in which people can stop the line, can feel comfortable addressing issues and concerns, So getting your leaders who already model those types of behaviors, I think engaged early on, could really help to move it forward and make the case to adopt the change package.
I love that. I love all of those answers. Thank you so much. We have a question about, and I'm going to direct this to Pauline, and it's what specific data does your organization share on the visual management boards? Does the board allow employees to submit questions and comments that are also publicly displayed?
I'll take the last one first. Yes, it does allow people to submit issues, concerns, and that actually is part of the infrastructure for how we escalate issues up through our tiered huddle structure. The data question depends on the level of the organization. So at our hospital level in Rochester, the data that gets displayed are our key performance indicators for the hospital as a whole, our quality, safety, and experience measures. But at a frontline level, at a nursing unit level, they might be focused on the bundles of CLABSI. They might be focused on fall prevention processes and tactics that Dr. Tittle mentioned earlier. So structure, process, and outcomes, but the further down in the organization you get, the more granular the data is, because it needs to focus on the things that staff can influence. So in that tiered huddle picture that I showed you, that unit is really focused on improving fall prevention. So part of the data on their display is, do we have fall prevention tactics in place for all of these high-risk fall patients on our unit this morning, this evening, because they do their huddles twice a day. That's just an example. So the data varies, but it needs to be meaningful for those that are using it.
Thank you. I love that. We have a question, and I think I'd like to direct this to all of you because you all have fantastic processes, and that is, what does your immediate response to serious safety events look like, and how has it evolved?
So I'm happy to take that one. So when there is a serious event, so we continuously remind folks of the events that we need to know about in our clinical risk management area. And we have someone, a patient safety officer, who immediately will investigate real time. If it is a sentinel event or has had a really significant safety impact on a patient, we will convene the group within 48 hours to do our root cause. We don't have to do that very often, and you don't want to do that very often because it is very disruptive. So when we need to, we do the root cause almost immediately. I think the other thing that's important is, how do you keep this in front of folks? And what we heard from staff over time was that, does anyone pay attention to these safety events that we put in? So every month we have a different theme card. It's a thank you card, and we send it from our clinical risk department folks to every person who submitted an event in that month, thanking them, letting them know that the event was, report was addressed, because very often people think it goes into a black hole.
I agree. Pauline or Shaw, do you have anything that you want to say about event response that is different?
Yeah, I think I appreciate the question focused on those serious safety events, and I'll echo Donna's comment that you, of course, hope these are very rare and infrequent. But I do think there's an immediate response to make sure that the caregivers and the team are well taken care of as well. Those events are dramatic for all those impacted. So I think there's an immediate response to kind of mitigate the harm of the additional harm to the patient, additional harm to the care team as well. But then you also need to immediately do an investigation. Mayo Clinic receives almost 60,000 patient safety events reported every year across our sites. I personally don't think that's even high enough because we want to hear about more and more events. And I think we all joked about that a little bit, not to make light of it, but how much we want those numbers to increase because it's signs of a good culture for reporting, and would love to move to more proactive intention around near miss, no harm safety events, and how do you approach those so that you're studying when things go right just as often as you're studying when things go wrong. But I think sharing the learnings from those is equally as important as the investigation, in as much a way as you can to protect the patient and the care team.
I love that. We have a few follow-up questions about event reporting and serious safety events specifically. So how do you share learning, specifically, how do you share learning with departments and staff from the serious safety events and RCAs in a meaningful way? And then are there examples you could share related to facilitating communication regarding patient needs and care across the organization?
I can take the facilitating communication about serious safety events. We consider it such an important discussion that I personally chair that committee, the Serious Safety Event Committee, and the safety and quality leadership teams at every one of our entities, including executive leadership, participate in that committee. And so every leadership team is on every meeting where we discuss the SSEs around the system, including the action plans with timelines, to correct the underlying processes that may have contributed to the safety event. And then we report that entire packet of information to our governing board. And so this happens on a monthly basis, and we make sure that everyone is apprised of all of our serious safety events. And if there are structural things that could contribute to that, we address them then.
We do things just a little bit differently here, but the whole concept is the same, making sure that first of all, there was a question about having an executive sponsor for the action items. So every one of our series events will include a senior level person as part of that root cause analysis and kind of sponsorship to whatever we need to move forward. Our quality directors at each of our campuses are reporting directly to the senior leadership team at that campus, but have a matrix reporting to our centralized staff, network directors. And so they meet and make sure that when there is something very serious and significant that needs to be addressed, that they're all on board and they take that back to their campuses, to their senior team, and communicate that at their campus.
There's a great follow-up question about how non-clinical team members are engaged in these event review efforts.
At Mayo Clinic, we manage things through that triad leadership model of the clinician, the administrator, and the physician, the administrator, and the nurse. So very few things we do don't have the triad leadership model engaged, but often we may encounter safety events that do involve environmental services staff, or that's a great example because of infection prevention techniques and things. And again, that focus on the needs of the patient. So hopefully if you'd ask an environmental services staff person, they are clinical. Their job is to prevent infection in our patients and keeping them safe. So everyone at the organization is considered part of the patient's journey and engaged in as such. I wanted to follow up a little bit on that cascading of the learnings, because I think our system, IT system that collects our patient safety events is integrated into our AHR to make it really easy to report. It also has a close the loop feature because we want to make sure we're getting back to the reporter and those peripherally around that event to let them know the event was closed and what we learned from it. We also host a variety, and I heard this from St. Luke's and Houston Methodist also. So I think all three of us host a variety of different learning labs or learning opportunities, whether it be poster fairs, celebrations of safety events, or good catches that are advertised really broadly across the organization. And then we also host a quality forum that's attended by about 500 to 600 people each month, where we kind of do a grand rounds type of approach and focus on a safety or quality or experience issue that may have occurred. So lots of different ways and different options to kind of cascade those opportunities and learnings.
One other thing that we do here is we actually teach our residents, fellows, and medical students all about our safety program, how to report. We do simulation in our simulation lab with our, again, GME folks on how to do a disclosure. We teach them how to do a root cause analysis so that they understand the fundamentals. And they are really good ambassadors throughout our entire network for making sure things get reported and for engaging and leading some of our activities and actions as follow-up.
That's huge. I want to put a pin in this concept of the closed loop communication, not just for root cause analysis and serious safety event follow-up, but in general, something that we noticed that was so important at all of these organizations is this concept of coming back to the staff after concerns or events have been noted and closing that loop. Even if a suggestion was made or a concern was raised and the answer might not be a popular answer. It's the closing the loop and getting back to the staff. And kind of align with that, we had a question come in about confidentiality. So how are you balancing the need to have closed loop communication and the need for confidentiality with event reports?
I think that's a pretty important question. And I think here is where you can vary a little bit from a one-size-fits-all approach, because some events are more sensitive than others, right? And if you prioritize the importance of the players in the event, which sometimes you have to do, the patient's needs are first. And the immediate team member who was participating in the care of that patient is too, right? So we want to be very respectful to the parties who were involved and only share information as it is pertinent to improving processes, standards, or having conversations about processes. We have a lot of conversations about the fact that if you had replaced any doctor or any nurse in any event, right, you could have had the exact same outcome. And so we talk about our different acronyms, right? Ours is ICARE, and the R is for respect. We take that respect very, very seriously here. And so with an attitude of respect, we examine these cases and we make sure that we release information that will be beneficial to the patients and the advancement of the organization and not detrimental to any one team member.
And I would follow up and say exactly the same thing. You know, out the gate, this is not about an individual person. It's about the system or process and looking at what occurred, what should have occurred, how did it fail in that process. So it takes the focus off of the individual providers to, the system and the process.
Excellent. We have two questions about workplace violence, and it's how do your systems handle workplace violence incidents? Are all departments involved in workplace violence prevention? And then another attendee kind of added, let's also discuss harassment, incivility, and disrespect when we're talking about workplace violence.
You
In
know,
Mayo Clinic, we have a similar corollary approach to patient safety. It's a very similar event reporting, engaging security. We also have a response process and a team dedicated to reaching out to the patient and helping with either dismissals or terminations if necessary for that type of behavior. It is not expected to be part of someone's job to put up with that. And we address it and deal with it very seriously. We also surround that team with some additional resources and have really upped our game, I would say, in providing training for those at the bedside caregivers to help them understand behavioral safety plans, how to document things so the entire care team is aware of the best way to approach that patient. If you need to have a witness or somebody with you anytime you go in the room, those types of things to try to keep our staff safe.
and I think it's important, you know, we think about patients having rights all the time, but patients and families also have responsibilities. And part of that responsibility is to treat our staff with respect. I think what I see more often than not is that our staff will tolerate being treated inappropriately by a patient or family. So getting in and helping our staff learn techniques to, you know, de-escalate situations that are going on and reinforcing that, you know, we want to address these types of things early on rather than tolerating them. And sometimes they get to a point where they can get exacerbated because we've not addressed them early on.
I completely agree with my colleagues. I have only one thing to add, which is in the state of Texas, we have something called a criminal trespass warrant. And if you have a patient who has acted violently toward a staff member, we have enacted those, we've pursued those. And so the patient is no longer welcome at our facility. We will bring them in for emergency care, stabilize them, and then transfer them. And that sends a message, most importantly, to the staff that we always have your back. And that was very specifically pursued in order to send a message to the staff, exactly what you said. We've all come through healthcare. People have acted inappropriately to us. What we have to do is not normalize bad behavior in a setting of healing.
I agree wholeheartedly. I think we have time for a very brief answer to one last question, and that is, does your organization follow a specific communication and resolution process like AHRQ's Candor? And do you have any tips or advice for creating a robust resolution process with a special focuses and resources for the caregiver?
Yes, and in a moment of candor, I will also reveal that we're reworking this actively right now because I don't think there's a spectacular answer for this problem for every situation. I do believe that, to everyone's point, the culture and attitude and respect and care and compassion we have for each other have to be our guiding principles. And at the end of the day, we do need to resolve these issues. An exact process that is a framework rather than a step-by-step instruction manual is very important. And so we are actively thinking about how do we evolve that into the next phase.
I would echo that, Dr. Tittle. Mayo Clinic doing the same. I think we've tried in the past to adopt candor or cuss words or those types of things. And I think that we need to use a tongue-in-cheek mayonize that for our culture and what it looks like at Mayo Clinic. And I think I would echo your same response for Houston Methodist.
I would just add one more thing. I think if your clinical risk management staff, your patient safety officers, once your staff can trust the response they will get from them, you know, and if they're treated consistently well, I think that's key.
Thank you so much to all of you. Now to the audience, we'll invite you to share with us in the chat. So based on what you've learned, how you use the change package to improve safety, and which actionable practices could you see your organization implementing? On behalf of AHRQ and the National Action Alliance, I'd like to thank our presenters so much and our audience for your continued commitment to patient and workforce safety. The event materials will be shared via email and posted on the National Action Alliance website in the coming weeks. And we look forward to you staying connected with the National Action Alliance and hope that you'll join us during our next webinar, which will be held in December. And please stay tuned for information on our website. Thank you again.
Thank you.
Thank you.